All right, we're going to talk through non-medical treatment options here. So after we've made social and environmental changes that we're able to, we've been seeking care, we've had the assessment, we have a diagnosis, and we're talking through treatment options. One of the main treatment options for anxiety symptoms is non-medical, and it's therapy. Therapy is appropriate for individuals with intellectual disability. Therapy does not necessarily mean sitting in armchairs in an office for 50 minutes once a week to discuss deep or abstract concepts. Sometimes it's much more broad than this. Sometimes it's doing play therapy or playing games, card games, board games. Sometimes it's not even doing that at all. Sometimes it involves having other people in the room. Sometimes it doesn't. But therapy does not mean we're laying on a couch and having a therapist sitting behind a notepad. There are multiple modalities of therapy as well, and many that have adaptations available for individuals with intellectual disability. So we're going to talk through some of these, highlighting behavioral interventions, cognitive behavioral therapy, supportive psychotherapy, exposure therapy, and group therapy. But this is not an extensive list, not an exhaustive list. In considering behavioral interventions, this honestly is one of the first things that I'm considering when I'm working with patients who have anxiety behaviors or anxiety symptoms. In the setting of addressing many other aspects too, I want to know what else is causing this change from baseline. As try as we might, people who are regularly working with these individuals, whether it's family members or care providers, teachers, they all have different experiences and biases and different ways to adapt to symptoms. And oftentimes having an independent behavioral evaluator, interventional specialist, can be really helpful to, if at all possible, have evaluations in their home, at school, work programs, wherever it may be, as many places as possible, to have evaluations where you have an objective observer who's looking at interactions with other people, any other situations, trying to identify what are some of these things that are leading into these behaviors, these anxiety symptoms. Behavioral interventions employ the ABC model, looking at antecedents, or what's going on before these behaviors, what are the specific behaviors we're concerned with, and what are the consequences, what happens because of these behaviors. Again, there should be an external evaluator. This assessment is done by a behavioral intervention specialist. This can be done, the assessment can be done through observation, as I kind of mentioned, by interview and functional analysis too, trying to see what kind of dysfunction is this causing. Behavioral intervention or behavioral assessments often have help with determining, is this behavioral or psychiatric? Meaning, are there psychiatric symptoms such as diagnosis of generalized anxiety disorder that is then leading into anxiety about a variety of topics, or I guess maybe a different example might be social anxiety. That if someone has social anxiety disorder, that they already have these anxious tendencies, anxious symptoms, but then they're also going out in public, and then they're having these behaviors, and then it's causing this other disruption for themselves and others. They can help, these assessments can help determine, is this behavioral or psychiatric? Oftentimes it's both. And then after this assessment, we can have behavioral interventions, creating a behavior support plan that includes antecedent controls, kind of like we talked about before. Are there any things in the environment that we can change to reduce those triggering or leading in situations? And then reinforcement strategies too. What can we change about the potential outcomes that may change those behaviors too? Next, we'll talk about cognitive behavioral therapy, another modality of therapy that's very effective in treating anxiety. It was developed by Dr. Beck, and it functions on the cognitive model. We have thoughts, feelings, and behaviors, and that these three separate things have interactions with all three. That's often put in a triangle formulation, that we often have situations that cause automatic thoughts. These thoughts create feelings within us that then produce behaviors. Through cognitive behavioral therapy, we attempt to change these maladaptive patterns of thought and behavior. CBT, as it's called, has much more structured sessions. There's typically, we review the past week, we go through homework, we go through a task during the appointment, and then we assign homework at the end. So there's much more structured sessions. There is homework or assignments between sessions, and typically this kind of therapy is a little more problem focused. Adaptations for those with intellectual disability include increased number of sessions, repetition of material, and including other care providers in session to reinforce the skills that are being learned during the CBT session. Supportive psychotherapy is another modality that is more directive, active on the part of the therapist as well, that is often reinforcing healthy coping skills and supportively addressing unhealthy or dysfunctional coping skills. This kind of therapy focuses on positive and supportive relationship between the patient and the therapist. This is a solitary form of therapy, but it is also the building block of so many other modalities of therapy. I would be hard pressed to name one kind of therapy that does not incorporate some aspect of supportive psychotherapy as well. Easy adaptations for doing supportive psychotherapy with those with ID include simplifying some of the interventions, increasing the number of sessions that you have, and augmenting these sessions with other activities. So this may be things like not just talking through what situations are causing anxiety and what can we do about it, but maybe we do some more role playing in therapy. Right, let's pretend that we're at school and we have to answer a question, and I'm the teacher now and you're the student. Let's practice what would it be like to have to answer that question. So you can do it through role playing. You can play games. You can also do drawing. Any other way to get patients engaged in more ways than just verbally. Exposure is another very effective form of therapy that is used for specific phobias. So things like fear of heights, fear of planes, fear of spiders, whatever it may be. There's different ways to do exposure therapy, either by flooding or by desensitization. So flooding being in a safe setting, in a therapy setting with a safe supportive therapist. And then you're flooding yourself with images or experiences or sensations of being either on a plane or seeing that whether it be spiders, and trying to figure out how can we endure that situation and know that it doesn't last forever. And gradually over time, that discomfort and dysfunction starts to reduce. The other way is through desensitization, where you have graded levels of exposure. So you might first, snakes, for example, you might start talking about snakes first, becoming more comfortable with talking about snakes. And then maybe we look up pictures online of snakes. Maybe we hold a pretend rubbery snake. And then maybe that escalates to going to a snake exhibit at a zoo. Again, this is in a safe setting with skilled therapists. Group therapy is another wonderful modality for addressing anxiety symptoms in intellectual disability. It's another safe environment where individuals can feel and find that I am not alone in experiencing this. And there's a sense of shared skill building as well. And then finally for therapy, this is not an exhaustive list, but the last one we'll touch on today is family therapy, emphasizing family function, contributions, and consequences from interactions between various family members, in that we know that these interpersonal interactions can cause varying levels of anxiety for different members of the family. And perhaps if we can get parents and siblings and other individuals involved, we might be able to see how we're all contributing to any distress that may be caused, may be experienced in this relationship. So that's where we're going to step into medication treatments. Please remember that we need to first determine the cause. Acetaminophen or Tylenol or ibuprofen do lower fever, but they don't treat the infection. We need to determine what are the goals of care in using medications to treat anxiety, and make sure that we have clear expectations of what those medications can do and what they can't do. I will often tell individuals working with me that I don't have a magic pill. I can't give you a pill that will take away all of your anxiety. But what if we could reduce your anxiety from a daily rating of 8 out of 10? What if we could get that down to a 5 out of 10 or even a 3 out of 10? That doesn't mean that it's gone, but it's much more manageable. And discussing what those goals may be that can help guide what medications you choose and kind of like how often you're following up and perhaps what doses of medications you need to be targeting. And then a really good a good rule of thumb is to start low and go slow. Individuals with ID are neurodivergent. We know that their neuroanatomy may respond differently to medications, and they may have a higher rate of having side effects to medications too. So as a general rule of thumb, when possible, if safe to do so, we want to try to start low and go slow. So we're going to touch on a couple of different classes of medications. I also want to back up and say this: we are reviewing these not to say that, not to hopefully come out of this presentation saying, okay, I know that this is the medication we need to ask for, but instead to get some understanding of what these medications are, how long should it take, what other kind of concerns should we have with these medications, and what can we expect. So First, one of the first-line medications for treating anxiety in intellectual disability and in the general population is SSRIs, or selective serotonin reuptake inhibitors. The generic names for these are sertraline, fluoxetine, or escitalopram. The brand names are things like Zoloft, Prozac, Lexapro, just for your own familiarity. Typically with these medications, it's going to take about 4 to 6 weeks before we start to see the most likely response to that dose. So it's not like we start taking this medication today and tomorrow I'm not feeling as anxious. You may start to see some response within a couple of weeks, but typically you're not going to see how an individual responds to that medication at that dose until 4 to 6 weeks. More common side effects are activation, feeling a little more energized, maybe even some sensation of anxiety that increases initially as their body gets used to the medication, upset stomach and headaches. And the more severe but less common side effects, there's FDA black box warnings about suicidal ideation in teens and young adults starting SSRIs, serotonin syndrome, which is an overload of serotonin in our system, leading to symptoms like flushing, tremors, confusion, sweating, fevers, and then mania, which is a symptom of bipolar disorder, which is significant increases in energy, decrease in sleep, grandiose thoughts, risk-taking behaviors that are all lasting 4 to 7 days or greater. Timeline for how long to be on medications, SSRIs, for example, depends on the response to medications. I'd like to talk through how I don't want to begin a medication expecting that once we start on this, we are forever on it. There may come a time where someone is stable enough and in a different situation, or we've managed other aspects of anxiety, that we can try going down a dose of medication. Typically, we don't do that until we've reached a point of stability, like 80% improvement for 6 to 12 months or more, and then we slowly come down on a medication and see how they respond. If someone doesn't do well, then we go up and we stay on it for a little bit longer. And the timeline of how long to be on the medication depends on the individual's response. Selective or serotonin norepinephrine reuptake inhibitors, SNRIs, are another class of medications used for anxiety and intellectual disability. Examples include venlafaxine or duloxetine. The brand names for these are Effexor or Cymbalta. They also take about 4 to 6 weeks to see the most likely response of that dose, and they have similar side effect profiles to the SSRIs. But these ones also have some different withdrawal reactions too. So if you come off of this medication too quickly, sometimes people can have neurological symptoms, such as like a zing down an arm, that if you forget to take medication for a day or a couple of days, if you're at a higher dose, you may start to experience that. So it's important when coming off of these medications, if necessary, to talk with the prescriber on a controlled way to do that. Buspirone is another medication that is often used in anxiety. We often use this 2 or 3 times a day. It can be used alone, but most often it's used to augment or add on to the other primary medication treatments like SSRIs or SNRIs. A few other medications that we'll cover is just beta blockers. Beta blockers are antihypertensive medications, so things that we use to lower someone's blood pressure, such as propranolol or metoprolol. Most commonly, we would use propranolol, and we use this often for panic disorder. It can reduce some of the physical symptoms of panic as well, can interrupt that physical symptom cycle. And we can use this to augment or add on to other anti-anxiety medications. Hydroxyzine is another medication that we often use as needed, and as needed as opposed to scheduled manner. So if someone is having anxiety symptoms, it's becoming overwhelming, I'm having a hard time regulating these symptoms, I can take this medication, and within 15 to 30 minutes, this hydroxyzine may help to reduce some of that anxiety. But it's not something, like, if you don't need it, you don't take it. Sometimes it can be scheduled, but oftentimes it's used as needed. Sometimes this can cause some sedation or sleepiness too. And then finally, want to just touch base with benzodiazepines, things like lorazepam, Valium, clonazepam. You really want to approach these medications with great caution. Benzodiazepines do have their place, but only with extreme caution and clarity of what are our goals, what is our plan for these medications, what's our intent here, and what's our long-term plan. These medications do come with long-term risks, especially when we're in or nearing geriatric age ranges. And sometimes benzos have been known to cause paradoxical reactions in individuals with intellectual disability, causing instead increased agitation or irritability as opposed to decreased. Again, it's not always, but it's not uncommon.